Alright, so what happens if you have too much ammonia, or in other words, if you're producing it faster than you can get rid of it? Well, excess ammonia in the blood, called hyperammonemia, is a serious medical condition that can cause hepatic encephalopathy. These patients will present with symptoms such as asterixis, which is a kind of tremor, slurring of speech, somnolence, vomiting, and blurred vision, and this can actually result in the patient's death due to cerebral edema. It can be caused by a few different problems. Hyperammonemia can be caused by liver disease, since that's where ammonia is converted into urea. Or disease can be due to a genetic deficiency of any of the urea cycle enzymes, which prevents the urea cycle from working properly. In either case, ammonia will build up and will be transferred to alpha-ketoglutarate to form glutamate, as we talked about here. This depletes your supply of alpha-ketoglutarate. Now, when the alpha-ketoglutarate supply is depleted, which important metabolic cycle is inhibited? Hopefully you're thinking TCA cycle. Okay, so how are we going to treat hyperammonemia? Well, the treatment of this condition is to limit protein in the diet. If you want to look like a rock star in clinical rotations, you should also be aware that you can give lactulose to acidify the GI tract. When you give lactulose, the ammonia gets converted to ammonium, which cannot cross the gut epithelium. This concept is called ion trapping, and you'll probably see this whenever you review for renal and pharmacology. The nitrogenous waste is now trapped in the GI lumen, so it'll be excreted rather than reabsorbed. Other options include giving rifaximin, which decreases the bacterial load in the gut that produces some of the ammonia. Amino acid binders such as benzoate or phenylbutyrate can also increase excretion of ammonia. Let's take a quick look back at the urea cycle. Do you remember what the rate-limiting step of the urea cycle is? The rate-limiting step is the reaction formed by carbamoyl phosphate synthetase 1, which converts ammonium and CO2, in the form of bicarbonate, into carbamoyl phosphate. How does the body regulate this enzymatic step? Well, N-acetylglutamate is a cofactor for the enzyme, carbamoyl phosphate synthetase 1. If N-acetylglutamate cannot be synthesized because you're missing the enzyme N-acetylglutamate synthase, the rate-limiting step for the urea cycle is inhibited, and hyperammonemia may occur. An N-acetylglutamate synthase deficiency presents the same as a carbamoyl phosphate 1 deficiency. However, if you have normal urea cycle enzymes with an increase in ornithine, this can suggest an N-acetylglutamate synthase deficiency. In both N-acetylglutamate synthase deficiency and carbamoyl phosphate synthase 1 deficiency, you'd see symptoms early in life, such as irregular breathing, poor temperature regulation, feeding difficulties, developmental delay, or intellectual disabilities. Speaking of urea cycle enzyme deficiencies, ornithine transcarbamylase deficiency is the most common urea cycle disorder. A lot of enzyme deficiencies I've mentioned are autosomal recessive, but this one is actually X-linked recessive. Now, can a male with ornithine transcarbamylase deficiency, an X-linked recessive disease, pass this trait off to his child? Well, yeah, we need to be careful with these types of questions though. So, he can pass his faulty X chromosome to his daughters, but he can't pass it off to his sons. The one exception is in Klinefelters, where you have XXY. Since it's an X-linked recessive disorder, his daughter would also have to receive a faulty X chromosome from her mother to have true ornithine transcarbamylase deficiency. Remember, the enzyme ornithine transcarbamylase is normally used to convert ornithine to citrulline by adding carbamoyl phosphate. Therefore, if you don't have this enzyme, carbamoyl phosphate will wind up building up. So, manifestations of ornithine transcarbamylase deficiency include orotic acid in the blood and urine, and decreased blood urea nitrogen, since urea can't be formed without this enzyme, and the symptoms of hyperammonemia that I described in the last slide, since ammonia can't be converted to urea. There's another disease besides ornithine transcarbamylase deficiency where you'll see orotic acid in the urine. Do you remember what it is? That disease would be orotic aciduria, which is caused by a defect in one of the enzymes that converts orotic acid to UMP. But do you remember how you can differentiate between orotic aciduria and ornithine transcarbamylase deficiency? Well, in the disease orotic aciduria, you won't have hyperammonemia, since ammonia is excreted via the urea cycle just fine. In ornithine transcarbamylase deficiency, you can't excrete nitrogenous waste via the urea cycle, so you get ammonia buildup in the blood. Okay, flash quiz time. A lethargic newborn boy with low BUN is diagnosed with the most common urea cycle disorder. What substance will you ultimately find in his blood? Well, this one's a little tricky. Hopefully you're thinking orotic acid, which is used for pyrimidine synthesis. Let's talk this one through. The child has ornithine transcarbamylase deficiency. In the figure, we have our ammonia, here in the form of ammonium ion, that gets converted into carbamoyl phosphate. Now, this carbamoyl phosphate has two options. It can enter the urea cycle, which we've covered. However, it can also be used to build pyrimidines. To reiterate, carbamoyl phosphate can also be used to build pyrimidines. Do you remember what the three pyrimidine nucleotides are? You just learned about these in the biochemistry molecular section. The pyrimidines are cytosine, thymine, and uracil. Here, we can see both metabolic processes that use carbamoyl phosphate side by side. So, if we have a urea cycle deficiency, such as ornithine transcarbamylase deficiency, the carbamoyl phosphate will switch pathways, leading to an orotic acid buildup. You'll also see high orotic acid in the urine in orotic aciduria, which is caused by a defect in one of the enzymes that converts orotic acid to UMP. But do you remember how you can differentiate these two? I'll give you a sec. Well, orotic aciduria won't have hyperammonemia, since you can still break down ammonia just fine. We now move on to some high-yield amino acid derivatives. Many important compounds within the body are derived from amino acids. Phenylalanine and its derivative tyrosine are precursors of the catecholamines, which include dopamine, norepinephrine, and epinephrine. Thyroid hormones are also derived from tyrosine, and the pigment melanin is derived from dopa. Please, don't confuse dopamine with dopa. Okay. Tryptophan uses B6 to make niacin, which is the precursor of the electron carriers NAD+, and NADP+. As a quick aside, how many ATP does NADH make when it exchanges its electrons in the electron transport chain? NADH has enough energy to synthesize about 2.5 ATP, while FADH synthesizes about 1.5 ATP. Using vitamin B6 and the cofactor tetrahydrobiopterin, which is used to transfer a hydroxyl group to a substrate, tryptophan can also be converted to serotonin. Serotonin can in turn be converted to melatonin, which is important for sleep. This is why people associate eating turkey on Thanksgiving with being tired after the meal, since turkeys have lots of tryptophan, which gets converted into high levels of melatonin. Also, please don't confuse melanin with melatonin. I remember the difference by alliterating serotonin and melatonin. They both have TO or toe in them. Vitamin B6 is also used in the conversion of histidine to histamine, which is important for the allergic response. Also, please don't confuse these. Now, let's focus on heme synthesis for a second. A third use of B6 is in the first step of heme synthesis, which is the conversion of glycine to porphyrin. Can you think of why a B6 deficiency can lead to sideroblastic anemia? Glycine is combined with succinyl-CoA by the enzyme allosynthetase to make delta-aminolevulinic acid in the rate-limiting step of heme synthesis, which is why a deficiency of vitamin B6 causes sideroblastic anemia. So, now back to our discussion on amino acid derivatives. Heme synthesis needs the amino acid glycine and vitamin B6. The amino acid arginine can be used to make creatinine, urea, and nitric oxide. And lastly, glutamate, which is a derivative of the inhibitory neurotransmitter GABA, using the cofactor B6, again, can be used to make glutathione, which is an antioxidant we talked about earlier that needs NADPH for its replenishment. So here we have the same pathway that we just saw with the amino acid derivative slide. It was a pretty basic pathway, so now let's fill in the picture a little bit. The catecholamines, which include dopamine, norepinephrine, and epinephrine, are the hormones derived from phenylalanine. The first step in catecholamine synthesis is the conversion from phenylalanine to tyrosine via the enzyme phenylalanine hydroxylase. This step requires tetrahydrobiopterin as a cofactor, which reduces it to dihydrobiopterin. Dihydrobiopterin reductase is used along with NADPH to restore dihydrobiopterin back to tetrahydrobiopterin, so it can be used again. Speaking of NADPH, what disease results from a decrease in NADPH synthesis, which can ultimately lead to RBC destruction in bite cells? This highly tested, high-yield, all-important disease is G6PD deficiency, where the enzyme glucose-6-phosphate dehydrogenase is defective or deficient. The second step in catecholamine synthesis converts tyrosine to dihydrophenylalanine, or DOPA for short. This step requires the enzyme tyrosine hydroxylase and again uses tetrahydrobiopterin as a cofactor. This step is very similar to the previous step we just saw, just with different enzymes. In the third step, DOPA is converted to dopamine, which requires vitamin B6 and DOPA decarboxylase. This is a step that's inhibited by carbidopa to treat Parkinson's disease. As you'll see in the neurology section, having too little dopamine generally causes Parkinsonism and/or Parkinson's disease. Do you know why a drug that inhibits dopamine synthesis actually helps patients with Parkinson? That's because it only inhibits this reaction outside the blood-brain barrier, or, in other words, in the periphery, which allows more DOPA to be available in the brain for conversion to dopamine. This way, there'll be higher levels of dopamine in the brain. Back to our catecholamine synthesis pathway. Dopamine is then converted to norepinephrine by the enzyme dopamine beta hydroxylase, which requires vitamin C as a cofactor. Now that we're thinking about it, do you remember what collagen disease results from a deficiency of vitamin C? The answer is scurvy, which we talked about earlier. Do you remember how scurvy presents? Well, scurvy presents with impaired wound healing, swollen gums, bruising, corkscrew hair, perifollicular and subperiosteal hemorrhages, and hamarthroses. Back in the day, sailors would run out of vitamin C while at sea. What's a pirate's favorite letter? You may think it's R, but their true love be for the C. Vitamin C is also used in the catecholamine synthesis pathway, where it's used as a cofactor to help convert dopamine into norepinephrine with dopamine beta hydroxylase. In the final step here, norepinephrine is converted to epinephrine by phenylethanolamine N-methyltransferase. Since this reaction adds a methyl group to norepinephrine, it should not be surprising that SAM is used as a cofactor to donate that methyl group. This enzyme is regulated by cortisol, so when cortisol levels increase due to stress, more epinephrine will be produced. You may also want to keep in mind that both dopamine and norepinephrine are produced in the central nervous system and also in peripheral tissues, but epinephrine is produced only in the medulla of the adrenal glands. Don't confuse this with the medulla of the kidney next door. Now that we spent all this time to build up catecholamines, how do we break them down? Well, catecholamines can be broken down by our Pac-Man enzymes, monoamine oxidase, otherwise known as MAO, or catechol O methyltransferase, aka CompT. Dopamine is broken down by MAO or CompT into homovalinic acid. Norepinephrine is broken down into VMA or vanillylmandelic acid. And lastly, epinephrine is broken down into metanephrine. In one disease, we use these breakdown products as a measure of the catecholamine production. A pheochromocytoma is a tumor of the adrenal medulla chromaffin cells that produces high amounts of catecholamines. You can use lab values of these breakdown products to help diagnose a pheochromocytoma. This disease is discussed more in detail later on in organ systems. Since we're out of catecholamine coins, we're going to call game over for the catecholamines. If you're following along in the first aid book, take a look at the catecholamine synthesis / catabolism figure. I like this figure of catecholamine synthesis / tyrosine catabolism because it shows how some diseases fit into the big picture. Now we'll go through some diseases that are caused by dysfunction of amino acid metabolism. Phenylketonuria, or PKU, is one of the most common enzyme deficiencies, with an incidence of 1 in 10,000. Since it's so common and so important to detect, the USMLE loves to test on PKU, or phenylketonuria. Make sure you know the mechanism and amino acids involved in this disease for test day. What can cause PKU? Phenylketonuria can be either caused by an autosomal recessive deficiency in phenylalanine hydroxylase, or by a deficiency in the cofactor tetrahydrobiopterin. Both of these are required to convert phenylalanine to tyrosine, so a deficiency in either results in a buildup of phenylalanine and also a tyrosine deficiency. The excess phenylalanine can then be converted to phenylketones, such as phenylacetate, phenylactate, and phenylpyruvate. These phenylketones get spilled into the urine, hence the clever name phenylketonuria. Tyrosine then becomes an essential amino acid because phenylalanine doesn't get converted to tyrosine, and if it isn't consumed enough in the diet, the catecholamines can't be produced. Thinking back to our discussion on catecholamine synthesis, phenylalanine is converted to tyrosine, which can then be converted into the catecholamines. Also, without tyrosine, you can't produce thyroxine or melanin. Consequently, patients with PKU will have intellectual disability, growth retardation due to a lack of thyroxine, seizures, fair skin due to lack of melanin, eczema, and a musty body odor, which is caused by the excess phenylketones. To remember this connection, keep in mind that the phenyl functional group is an aromatic green, and patients will thus have a distinctive aroma. If you see the words musty odor on testate, immediately think of phenylketonuria. If a patient's diagnosed with PKU, how you treat this disorder? The treatment of PKU is to eat less phenylalanine and more tyrosine. Since artificial sweeteners such as aspartame and NutraSweet contain phenylalanine, patients with PKU should avoid these. If you have a soda or pop can in front of you, check out the label. Most diet soda or pop cans will say something along the lines of phenylketonurics contains phenylalanine. PKU can also arise in a fetus if a mother does not have a sufficient dietary intake of aromatic amino acids. Infants from these mothers have microcephaly, mental and growth retardation, and congenital heart defects. You'll see the same congenital defects if the mother has PKU and does not adhere to her dietary restrictions, since phenylalanine and its phenylketones can cross the placenta. Newborns are often screened for this disease 2 or 3 days after birth. The reason it isn't immediately checked for is because some maternal phenylalanine hydroxylase may be in fetal circulation in the first few days of life. Okay, flash quiz time. A 3-day-old infant has elevated urine phenylacetate, phenylactate, and phenylpyruvate. What are the 2 possible defects? This question is basically asking, what are the defects that cause phenylketones to accumulate? The first defect could be due to a missing enzyme, phenylalanine hydroxylase. However, remember that this reaction also requires a cofactor, tetrahydrobiopterin. If either of these 2 are missing, phenylalanine is not able to be converted to tyrosine or its derivatives.